Uh, Hello everyone, and welcome to this session on this wonderful Wednesday. And our speaker today is Dr. Musa from Cleveland Clinic. And to moderate this session, we have Dr. Dinesh Nayak. Can we have Dr. Nayak sir's CV slide, please? So Dr. Nayak actually needs no introduction in this forum. And honestly, if we were to draw a pedigree chart of teachers and students, then most of us would have been linked to him either directly or indirectly. So, sir, it's an honor to have you amongst us today, and I'll request you to please unmute yourself and take it on from here. Thank you, sir.
Thank you. Thank you very much, Vishal, for the very kind introduction, and thank you for inviting me to this the school. And I have very great pleasure in introducing one of the brightest pediatric epileptologists internationally now, my good friend and colleague, Dr. Ahsan Musa. He is right now at the Cleveland Clinic in Ohio, and he's had a very distinguished career. Now, he started off as DM. He actually is from my home state, which is Tamil Nadu. He did his basic medicine from Tanjavur Medical College, and then he did his pediatrics from PGI Chandigarh. So he's a very bright person. And then he came to Sri Chitra. That's the time when I just had left. And he just joined in 1998. And then he completed his DM neurology, and he was considered to be one of the finest residents at the time. And he completed it in 2000. And then he continued to be in Chitra for some time. And I think he revamped the intensive care unit. That's what I was told when I came back from UK, when I came back and rejoined Chitra, by which time Dr. Musa had left, but he left an indelible mark in Sri Chitra. Everybody was talking about Musa's contribution to the revamping of the ICU setup there. And then after that, he decided, I think I remember the first pediatric epilepsy conference that Chitra held with Cleveland Clinic in January of 2006. And Musa gave a very nice talk. And I think it impressed Elaine Wiley at the time. And I remember that. And that had a big impact on Musa. And then he decided to move over to US. And he went to Cleveland and got trained in epilepsy. He had his epilepsy fellowship, the clinical neurophysiology fellowship, the EEG fellowship, the pediatrics training and all that. And now he's a consultant there. And he is in the limelight. He's had a lot of work has been done by him and his co-workers. And some of his most notable contributions has been in the field of hemispherectomy in children, hemispherectomy in children as well as in adults. I think that's those papers are wonderful, those series, and the kind of the workup as well as the follow-up and all that is really remarkable. There's no doubt about that. I think last year we had a very nice talk by him on hemispherectomy, and it was really wonderful. So I'm sure that Musa is going to do a lot of justice to today's talk, which is going to be on drug interactions in epilepsy. It's a very practical talk. And this is very important because over the last 2 decades, we have seen so many newer anti-seizure molecules that have come in, at least about 25 drugs that we have right now in our armamentarium, the first generation, the second generation, and the third generation anti-seizure medications. And we'll have to grapple with the pharmacokinetics, the pharmacodynamics of all of these agents, and how they interact within each other. That is the 2 or 3 anti-seizure medicines that we are sometimes forced to use in more difficult to control seizures. And we need to have a good idea about the interactions as well as the interactions with other medications. For example, if somebody is on an antimicrobial drug or an anti-neoplastic drug or various different categories of medication, what are the pharmacokinetics and the pharmacodynamics, and what are the interactions which can be very, very clinically relevant? It's not just theoretical, but it's very important to have an idea about what a drug can do to the body, what two drugs can interact and how it can affect various systems. And that's what Dr. Musa is going to talk about today. It's a very clinically relevant topic. So with these few words, it's over to Dr. Musa. Thank you.
Good evening, everybody. Can you hear me?
Yeah, you're good.
Okay, thank you. Thank you, Dr. Naik, for that kind and gracious introduction. I don't know whether I deserve them, but I'll take them for today. I thank Dr. Vishal and the organizers of the AOCN for inviting me to give this talk. In fact, Dr. Vishal asked me to talk about newer anti-seizure medications. I made a counteroffer to talk on a topic that I love to talk about with my colleagues and trainees here. Thank you, Dr. Vishal, for graciously accepting my request to change of the subject. As Dr. Naik said, drug-to-drug interaction is a very important part of epilepsy medicine. It's a relatively difficult subject to master in epilepsy practice because there are many, many drug interactions. Some of them are clinically significant, others not so much. Without a logical approach to the problem, the task of remembering all these drug interactions can be vexing, and it's not easy to remember them. I should say upfront that I'm no certified expert in drug interactions. I'm not a walking encyclopedia of drug interactions, very far from it. I'm pretty sure I was talking to the panelist earlier that some of you in the group knows more about the subject than me. That's always a possibility when we talk to a group of physicians in India. No matter what the subject is, there's somebody in the audience who is more knowledgeable. But I'll try to make this talk clinically meaningful, focusing on clinically relevant drug interactions without overwhelming you with too much information, hopefully. I would love this talk to be interactive, but I understand that there are limitations for this in a virtual format. I've inserted a few multiple choice questions there, and whenever possible, please type your answer in the chat section there. So in the first section of the talk, I will use some clinical scenarios to showcase certain principles of drug interactions with an overview of pharmacokinetic mechanisms. I plan to review this topic from several different angles. I will highlight some information about various enzyme systems and the drug substrates involved in those systems. Talk about some enzyme inducers, enzyme inhibitors, affected drugs and offended drugs, and so on and so forth. I hope such a mesh of knowledge will help you to remember these interactions better. Although newer medications are less prone to drug interactions, there are some notable exceptions, and this will be highlighted throughout the talk and with particular reference to CBDs and ketogenic diet. Lastly, I will also review some interactions between anti-seizure medications and other medications used for other indications, like birth control medications and also other systemic medications, as Dr. Naik highlighted. I will not be discussing about pharmacodynamic interactions with this talk, and I won't be discussing about any interactions at the gut level or the absorption level in the system with the medications. So in general, the effect of drug interactions are twofold. Number one, the drug level could increase, and that would lead to toxicity related to the drug. Or the drug levels could fall, which would lead to increased chances for having a seizure recurrence. And the drug levels are altered because of alterations in the clearance mechanisms of these drugs. Either the metabolism of the drug is increased or inhibited, leading to decrease in levels or increase in levels. Or sometimes the clearance of a metabolite, which may be an active metabolite, may be impaired. Less commonly, one could have interactions related to displacement of the protein binding. And as I said, sometimes at the absorption level, at the gut level, also drug interactions could happen, which we will not be talking about in this talk today. Let's talk about a case. This is a case I had probably in my initial few months of becoming a consultant epileptologist at Cleveland Clinic. I probably would have a different approach to the management of this patient at this time, but this is what happened. I think this has got a very educative, illustrative case here. So this was a 6-year-old boy with Mowat-Wilson syndrome. We don't need to know about that syndrome. He was having seizures. He had a prior episode of status epilepticus, and subsequently he was on anti-seizure medication for 2 years on valproate. He presented with a breakthrough seizures triggered by some infection. He went into status epilepticus. He became refractory to first-line medications, second-line medications, and subsequently he was put on pentobarbital infusion. The other medications included piperacillin tazobactam for pneumonia. And the scenario is about the valproate level during the ICU stay. When he came in, he was on his home dose of 750 milligram per day, so about 44 milligram per kg per day. His level was 106. So missing the dose was not the reason for the status. But over the next few days, we had trouble maintaining his blood level because the blood levels were consistently decreasing over time. We were trying to keep these medicines in the system because this is something that helped the patient for a long time, keeping him seizure-free for 2 years. So we thought that maybe we should try to maintain this medicine. We kind of pushed the dose further and further, and the levels kept dropping and dropping. And this is what happened. I think he ended up almost 4 times the initial dose of the valproate. We're giving multiple times a day IV preparation. And the question is about all of the following are caused lower levels of valproate, except number 1, enzymatic induction from phenytoin, enzymatic induction from phenobarbital, co-administration of piperacillin tazobactam, none of the above. So it's a question with the except. I'm not able to see the audience responses there. I do not know whether the other panelists are able to see. Is there something I will be able to see here? Dr. Naik. Oh yeah, I think I need to click the chat here. Okay, someone says except 3. I think most people are choosing 3. Yep, I think I got multiple responses with 3, which is the right answer. Let's see here. Is this slide not moving? Okay. Okay, first let's talk about some major drug elimination mechanisms involved in elimination of the anti-seizure medications. Broadly speaking, you have a hepatic and renal mechanisms. And the hepatic, you often come across the cytochrome oxidase enzymes. And some of the common isozymes in the cytochrome oxidase family are 2C19 and 2C9, which has got the specific substrates here. So you can see 2C19. The common substrates are phenytoin, glucosamide, and a clobazam metabolite. The clobazam is converted into desmethylclobazam, which need to be eliminated after passing through the 2C19 enzyme. 2C9, the substrates are phenytoin, phenobarbital, valproate. 3A4, the predominant substrate is the carbamazepine, is the most common substrate. But the other medications that are metabolized to these medicines include felbamate and zonisamide as well. The other enzymatic mechanism is the UGT, which is UDP glucosyl transferase. The most important drug that is metabolized through this pathway is the lamotrigine. A small proportion of valproate as well as lorazepam also undergoes glucuronidation. And thirdly, carbamazepine epoxide that is metabolized by the epoxide hydrolase. Carbamazepine epoxide is a toxic metabolite of carbamazepine that needs to be eliminated by this epoxide hydrolase. And several of the medications, especially the newer medications, have predominantly renal eliminations. In fact, gabapentin, pregabalin, vigabatrin have more than 90% clearance by the kidneys. Levetiracetam is about 2/3 is eliminated by the kidneys. And these 4 medications, felbamate, lacosamide, topiramate, zonisamide, anywhere from 30 to 50% of the clearance is predominantly by the renal mechanisms. So if you look at the valproate, if you look at the scenario of the initial scenario where the valproate levels were plummeting despite increasing the dose, that's because of the enzyme interaction where there was an enzyme induction that was happening that was increasing the elimination of valproate. If you look at the valproate metabolism, there's got multiple pathways of metabolism. Elimination in cytochrome oxidase is one of the major pathway of the mechanism. And if you look at the inducers, most of the first generation medications, which is the phenytoin, phenobarbital, primidone, carbamazepine, they are all multiple enzyme inducers. They often induce multiple enzymes. Usually the enzyme inhibitors, they tend to be a little bit more restricted to 1 or 2 specific enzymes. But if the first generation enzyme inducers, they induce multiple enzymes. So that was the reason why the patient's levels were dropping further and further. And I understand that I tried to add an antibiotic here. I'm sure some of you are familiar with another antibiotic that interferes with the valproate metabolism. We will talk about it in the later part of the talk. So if you look at the list of enzyme inducers, as I highlighted, the first generations have multiple enzyme inducers, but some of the newer medications also have some enzyme induction properties, specifically for the CYP3A4 induction. Felbamate, oxcarbazepine, topiramate, especially in higher doses, rufinamide, perampanel, all of them can produce some CYP3A4 induction. And the importance of CYP3A4 is almost 40 to 50% of drugs in the market have involved CYP3A4 mechanism. And one of the important medication women use is birth control pills that is metabolized through this. So if you look at the medication, the anti-seizure medication that affects the birth control pills, the estrogen-containing birth control pills, these are the list of medications. CYP2C9 inducer, vigabatrin, is probably less commonly used in adult practice in particular. So if you come back to case 1, this patient got controlled with status epilepticus. We could wean off from the ventilator, weaned off from pentobarbital, and we were anticipating something. Okay, we were topping some of the medications. And what happened at the rehab was we were checking his blood levels, and the blood levels were initially on the lower side, and then blood levels slightly gradually increasing because we were anticipating the blood levels to go up. As you can see, we gradually reduced the dose, and finally, at a dose of around 1200, the levels were maintained around 100. For those of you who may not be doing valproate levels frequently, the reference range is between 50 to 100. And most people with difficult to control epilepsy, we try to keep closer to 80 to 100. We're talking only about the total levels. So what was happening in the rehab hospital here? We had discontinued the pentobarbital, and also we had discontinued the phenobarbital in some time later. And a few weeks later, we started noticing that the levels were climbing up, and we had to actively reduce the dose of the Depakote levels. And what was happening here was the enzyme de-induction, which can be delayed. If you start an enzyme inducer, it takes a few days for the enzyme induction to kick in. The same thing happens if you stop an enzyme inducer, it will take a few days for the enzyme induction to go away. So as you can see, enzyme inducers usually produce low blood levels, but when you're stopping the enzyme inducer, there is a risk for drug toxicity. So if you are not actively managing this, if you continue the same levels, this patient will have a significant valproate toxicity. So in terms of the newer seizure medications and the enzyme inducers, as I said earlier, these are the prominent ones. Most of them induce CYP3A4, predominantly affecting the birth control pills. And felbamate in particular has an interaction affecting the carbamazepine levels. All these medications, theoretically can produce a reduction of the levels of the other anti-seizure medication substrate that is metabolized through the CYP3A4 pathway. But some of them are more clinically relevant and others less relevant. Moving on to second case here. Again, there is a multiple audience, multiple choice. It's a multiple choice questions. Encourage audience response here. So this is a 21-year-old young man with juvenile myoclonic epilepsy on lamotrigine at a dose of 200 milligram twice daily. He was admitted with recurrent generalized tonic-clonic seizures. His lamotrigine level was 13.2. The reference range for the lab was 2 to 14. We elect to start valproate. He received a loading dose of 1 gram of valproate. What adjustment to lamotrigine dose you will make? The options are reduce the lamotrigine dose by 10% 2 weeks later. Number 2, lamotrigine dose reduction 10% from the next dose. Number 3, lamotrigine dose reduction 2 weeks later by 50%. And number 4, reduce lamotrigine dose by 50% from the next dose. I'm going to pause here and see for the responses. Yep, everybody's going crazy with number 4 options. That's correct. So if you look at the metabolism of lamotrigine, its metabolism is inhibited by valproate at the level of the UGT enzyme here. That leads to decreased clearance of the lamotrigine by 50%. And this inhibition may occur as soon as an hour. In one of these studies, after they gave an adequate dose of valproate infusion, the clearance was decreased in the next hour itself. So it has to be actively managed. So if you're giving a sufficient dose of valproate, cut down the dose of lamotrigine by 50% right away. In my practice, I usually change if the patient was on a twice daily dose of lamotrigine, I often make them as well as once daily and reduce the total dose by 50% or closer to 50%. In this patient scenario, the levels are already at the upper end of the range. So it is definitely very important to reduce by 50%. So if you look at the enzyme inhibitors, the valproate enzyme inhibition with the interacting with the lamotrigine is probably the most well known. And there are other enzyme inhibitors that we need to be aware of, or the I think with the use of cannabidiol, Epidiolex. It's a potent inhibitor of 2C19, which specifically affects the metabolite of clobazam. And cenobamate, another newer anti-medication, as well as felbamate, topiramate, can inhibit 2C19 enzymes, specifically affecting phenytoin levels in particular. And of course, it can affect the metabolite of clobazam as well. Valproate inhibits 2 enzyme systems here. It can increase the phenytoin levels. And stiripentol is another medicine which has got a multiple enzyme inhibition. That's why whenever you start stiripentol or valproate or felbamate, you should always look for other medications. What are the potentials for drug interactions here, especially with the multiple drug interactions, especially with the first generation medication. If it is there in the system, they are more likely to have interactions. In terms of epoxide hydrolase, valproate, felbamate, and brivaracetam, all of these things can produce epoxide hydrolase inhibition, which means that carbamazepine metabolite could be increased if the patients were exposed to these medications. So the other common clinically relevant examples of enzyme inhibition producing interaction includes felbamate increasing phenytoin levels, felbamate increasing carbamazepine epoxide levels. Valproate can increase furosemide levels also, but it's less dramatic than the lamotrigine. And valproate can increase carbamazepine epoxide level as well as by the inhibition of the epoxide hydrolase. If you look at the newer anti-seizure medications, cannabidiol, we'll talk about it a little bit more later. Again, it's got a multiple enzyme systems are inhibited, and the most important drug interaction is where clobazam metabolite increase. Brivaracetam inhibits epoxide hydrolase, increasing carbamazepine epoxide. Cenobamate affecting phenytoin and phenobarbital levels by the inhibition of this. And clobazam can inhibit one of the other enzymes, especially a product in cough syrups in particular. And lastly, carbamazepine could increase phenytoin levels by the CYP2C19. So again, newer medications, they are not exception. They are generally less. They are generally more, isolated enzyme inhibition or isolated enzyme induction. But one need to be aware of this when you do polytherapy. Here are some key differences between enzyme inhibition and the enzyme induction related drug interactions. Enzyme inhibition often affect the drugs immediately. As I said, valproate inhibiting the enzyme pathway for lamotrigine happens within an hour. So enzyme inhibition pathways often kick in pretty quickly. On the other hand, enzyme induction may take 1 to 3 weeks to kick in. So if you're not watchful for drug levels dropping when you're starting enzyme induction, you may completely miss, and the patient may be admitted with the recurrence of seizures. Okay. The same thing particularly happens in the ICU situations where in the emergency situation, we often end up using some of the enzyme inducers like phenytoin, phenobarbital, pentobarbital. And the levels of other medications may start dropping within a few days after you start these medications. Number 2, the enzyme inhibition often leads to dramatic, clinically significant interactions because of acute toxicity. It's a sudden increase in clobazam levels. Patients become drowsy, sleepy. It is not. We have had at least a couple of admissions to the ICU because of excessive clobazam level when the patients were taking Epidiolex, the cannabidiol altogether. So the drug toxicity is often dramatic, whereas enzyme induction related ones may be completely missed unless you check the AED levels or when the seizures occur. Seizures recurrence in a patient with epilepsy is unfortunately is an expected thing. It's not as dramatic as the drug toxicity. So enzyme inhibition toxicity is pretty dramatic. And enzyme inhibition is often selective with narrow spectrum of 1 to 2 enzymes. There are some exceptions. Obviously, siripental has got a multiple enzyme inhibition property, whereas enzyme induction, especially with the first generation medications, is often broad with multiple enzyme substrates, enzyme pathways induced. Enzyme inhibition is very important to anticipate and forewarn and to be proactive in many situations. If you're starting Depakote on somebody is on lamotrigine, you need to reduce the lamotrigine level. The same thing probably holds true for clobazam and cannabidiol. In my practice, I have invariably have to reduce the clobazam dose by at least 30 to 50% when I'm starting a patient on the cannabidiol. In my practice, only one patient who did not have an excessive sedation with the addition of cannabidiol. So it is very important. Most people would do a reduction maybe 20 to 30% right away when they start cannabidiol if the patient is already on clobazam. Sometimes the families may be reluctant to reduce the medicine because that was helpful in the past. So in that case, we had to warn them that, hey, if a child develops excessive sedation, this is the most likely reason, give us a call. We will reduce the medicines right away. But most of the times I do proactively 30% drop in clobazam and then adjust the dose further depending upon symptoms of toxicity. As I said earlier, after stopping an inducer, it takes around 1 to 3 weeks for the induction to subside. If the patient was on medication, I recently had a patient who was similar situation, refractory status epilepticus, pentobarbital, and the patient was on levetiracetam, generally not that affected by the enzyme induction, but we were giving levetiracetam of dose of around 8 grams per day to get a level barely in the 10s to 15s. And once the enzyme inducers were taken away, the levels kind of started climbing up quickly. Within a few weeks, with only 2 grams, we could get a very good levels of levetiracetam. So we need to be actively anticipating drug level changes when the patient is moving out of the ICU, especially when they are exposed to enzyme inducers in the ICU. Case number 3. So this is a case I took care of maybe 7 years ago. There's a 16-year-old young man with refractory epilepsy due to sodium channel 8A mutation. He was admitted to the epilepsy monitoring unit for increased seizures. And we are making some medication changes, which included addition of valproate and topiramate. And the patient was already on phenytoin at that time. And one of the thing we were doing at that time, it was in 2004. We did not have much information about SCN8A mutation and precision therapies. He was on phenytoin. We were trying to wean off the phenytoin, and he had some phenytoin toxicity of gum hyperplasia and all. So this is the phenytoin. This is the dose of valproate here. You can see 750 twice daily, and the topiramate dose is being slowly built up. And we look at the phenytoin levels, it ranging from 7.4 to begin with, and then 21 here. But the patient had significant ataxia and nystagmus by this time. The question is, what is the cause for this significant ataxia? The reason for ataxia is, number one, at high levels of total phenytoin, free phenytoin levels disproportionately increase. So we don't have the free phenytoin level listed here. Valproate protein binding displacing phenytoin, number two. Number three, inhibition of CYP2C19 by topiramate. And number four, patients with SCN mutation are prone to ataxia due to phenytoin. Let me pause here for a few seconds and see if you guys have responses here. I see 2, 1, 3, 2. So this one has got a slightly different responses from different, which means that this is probably of more instructive value here. Okay, so the answer is valproate protein binding displacing phenytoin, because we did check the free phenytoin level. Let's talk about the options here. At high levels of total phenytoin, free levels disproportionately increase. That's not true with phenytoin. We know that the phenytoin has got the zero order kinetics, where there is a slight increase in dose will have an exponential increase in the levels, but it's not necessarily the free levels. But the first one is applicable for valproate. There is a disproportionate increase in free levels because of the valproate protein binding has got a saturation at a higher dose. And inhibition of CYP3C19 by topiramate, it is true, but it should not be increasing the free phenytoin level. It will only increase the total phenytoin level. And the free phenytoin level is usually around 10% of the total phenytoin, 10 to 20%, I would say. And patients with SCN1A mutation prone to ataxia, that is not true. I think we know that the phenytoin producing disproportionate ataxia in some of the progressive myoclonic epilepsy syndromes, but in SCN1A mutation, SCN8A mutation, with a toxic gain of function mutations, phenytoin is a preferred drug, especially they often require higher doses. So this patient had free phenytoin levels drawn. I'm going to show you here the free phenytoin level. Even with 7.4, the free phenytoin level was pretty good. And 12.4, 2.4, with 21, which is a fairly good total phenytoin level, the free phenytoin was almost very toxic range here. So that was what is happening. The valproate was displacing the protein binding of the phenytoin, leading to increased phenytoin levels, free phenytoin levels. So the protein binding causes clinically relevant drug interactions only if the protein binding is very high. It is more than 90s, 40%, 50%, 60%, you don't have to worry about it at all. Even with more than 90%, it doesn't happen with all the medications. In fact, the only clinically significant drug interaction in epilepsy practice related to protein binding is between phenytoin and valproate. As you know, the bound drugs are inactive. The free drugs are the active drugs. So that's why there is an increase in free drug. Patients could experience toxic side effects. So the highly protein bound drugs are here: phenytoin, valproate, diazepam. We're talking about more than 90% protein bound, tiagabin, perampanel. It is not just the protein binding alone. Probably there are other factors in terms of the hepatic clearance. There is an extraction ratio at the level of liver that also influences the free levels of these medications. That's why we don't see much of a problem with protein binding interaction with the other medications. So for practical purposes, you need to remember only the phenytoin and the valproate. And in particular, these protein binding related drug interactions are usually transient, because as there is more free drug in the system, it is better cleared. and usually does not lead to major long-term concerns. So the patient, even if you don't make any dose adjustments, within 1 to 2 weeks, there is a new way of eliminating the drug. The free drug will be eliminated. So the drug interaction is no longer an issue after some time. But during the acute phase, if you add this medication, you could see patients having toxicity features. So important to check free levels in the acute phase. As I said earlier, there are other factors that influence, like the hepatic extraction ratio and the route of administration. That may be the reason why the issue is not a problem with many of the other medications. Valproate protein binding is, in a way, it's unique because the binding is saturable at therapeutic concentrations, with a free fraction of valproate increasing as the total concentration increases. So there is a nonlinear increase in the free fraction at the upper end of the dose range. The free levels are about 7% at 50 milligrams per liter in the blood level, compared to 30% at 150 milligrams. So they could have a disproportionately increased toxicity features at the upper end of the range. And so it's very important, especially in high dose upper end of total levels. It's important to check free levels as well. In my practice, I always check free levels for phenytoin. We also check we also have the availability of checking free levels for phenobarbital and valproate, but we do it only in special circumstances. In this scenario, as some of you had responded to chosen option number 2, where there is a inhibition of CYP2C19 by topiramate, there are 2 interactions in this scenario. If you carefully look at it, on the left-hand side, in the first column here, there is a decrease in the dose of phenytoin. We had decreased from 150 twice daily to 100 twice daily because of this. But despite that, the total phenytoin level was kept increasing. I think that this is because of these medications. Both valproate and topiramate have enzyme inhibiting properties, may have a slight increase in the phenytoin level, usually not very dramatic. But there is, in certain patients, the response could be very dramatic. So there are probably a combination of increased total level despite lower phenytoin level because of the enzyme inhibition. But of course, the most important thing is the toxicity due to high free levels in this scenario. And coming back to the slide with the enzyme inhibitors, as I highlighted earlier, topiramate and valproate, both of them have enzyme inhibition for 2C19, and valproate has got both 2C9 and 2C19. And the phenytoin is a substrate for both 2C9 and 2C19. In terms of other interactions, I think with the use of cannabidiol, the preparation that is only preparation that is available to us here is Epidiolex. The most notable drug interaction is because of its potent inhibition of CYP2C19. And it also inhibits other CYP enzymes as well. In a recent publication a couple of years ago here, they looked at the levels of different seizure medications that patients were on when they are taking cannabidiol. And as you can see, the most important thing is the clobazam, and the other medication that could be, the levels could be higher include topiramate, zonisamide, eslicarbazepine, and rufinamide. All of them had a significantly higher levels, especially in eslicarbazepine or zonisamide, particularly in adults. There was an increase in the levels. I have never understood why this CYP2C9 doesn't affect the phenytoin level in this. There are probably other reasons for this. So one cannot always remember just the enzyme substrate and the mechanism and the enzymes involved to predict the drug interactions. But obviously, it gives you more information. But you need to be mindful that sometimes the levels are not affected despite what the biochemical mechanisms tell you. The other important thing to remember is interactions with modified Atkins diet or any form of ketogenic diet for that matter. In this study of 63 adults on modified Atkins diet who are on diet for a 3-month period, the anti-seizure medication levels were tested. And they found that there is a significant reduction in clobazam in particular. There's the largest reduction, about 1/3 reduction. Valproate, which I have always noticed in our ketogenic diet clinics, when we start ketogenic diet, valproate levels kind of go down. I'm glad to see that has been published here. Carbamazepine is another that is medication that levels fall with ketogenic diet. And there is a mild reduction of these three medications, lacosamide, lamotrigine, and topiramate, that can happen with modified Atkins diet. And in this study, they did not find any change in levels of the oxcarbazepine or zonisamide or levetiracetam. So in summary, the pharmacokinetic drug interactions, they basically form under three major sections: the enzyme induction, which lead to reduction in the drug levels for obvious reasons, and the enzyme inhibition, which increase the drug levels, and the protein binding, which usually produce transient problems of toxicity and increasing the free levels here. And some interactions are much more complex, especially the interactions of carbamazepine deserve special mention here. Carbamazepine is converted into carbamazepine epoxide by the CYP3A4 enzyme. Interestingly, carbamazepine is also an enzyme inducer of the CYP3A4. That's why it's called autoinduction. That's the reason why when you start the carbamazepine, you always start low dose and slowly increase the dose. Because if you're starting at a 5 mg/kg at the starting dose, the levels may be pretty good because the enzyme induction has not kicked in. Whereas when you slowly increase the dose to 15 mg/kg, the levels may still be the same as the 5 mg/kg because the enzyme induction is kicked in and is balancing. On the contrary, if you start the dose right away at the beginning, patients may have toxicity features. And of course, there is a higher risk for other drug reactions, allergic reactions, Stevens-Johnson syndrome, and so on and so forth. But the auto-induction thing kicks in over a few days or weeks. That's another reason why we go up slowly on the carbamazepine. So carbamazepine is converted to carbamazepine epoxide here by CYP3A4, and the epoxide is converted into this metabolized dihydrodiol epoxide by the epoxide hydrolase. If you look at the medications that induce a CYP3A4, phenytoin, all the first generation, including the felbamate, and as I said, carbamazepine is an auto-inducer. And there are a lot of different products, over-the-counter products. Some herbal preparations can inhibit the CYP3A4. That's another important reason for the toxicity here. So grapefruit juice in particular and stiripentol among the anti-seizure medications is a powerful inhibitor of the CYP3A4 here. On the other hand, the medication that inhibits the epoxide hydrolase include valproate, felbamate, and brivaracetam. So as you can see, felbamate affects the metabolism in two different ways. So if a patient is started on felbamate, a patient could have carbamazepine toxicity. But if you look at the levels of the carbamazepine, they may be low. Unless you check the carbamazepine epoxide levels, you may not recognize that the patient is having toxicity because of this. So that's another reason why you need to be important. You need to be anticipating when you're adding certain medications, especially the medications with this significant enzyme inhibition properties like a felbamate and stiripentol, valproate. You need to be extra careful about what are the other medicines on the board and be watchful for drug interactions. This is a nice cartoon. This was published a few years ago by Peruka and Zakara there. I will walk you through this cartoon. I think it's a very, very comprehensive guide as of 2014, I would say. So this is a drug on the rows from top to bottom is the anti-epileptic drug that was added, and on the columns we have the previously existing medications, and there is color coding here. As you can see, there is for red means there is marked increase in the serum concentration. Blue means marked decrease in the serum concentration, which means that marked increase means there is probably an inhibitory mechanism going on. And marked decrease means there is an enzyme induction mechanism going on. And if you see more red, obviously those are the drugs that you need to be more careful with that. So let's take a look at the felbamate here. felbamate, what does it do? It increases the phenytoin, phenobarbital, and valproate here. Okay. And valproate, look at this, it increases the lamotrigine interaction here, significant increase in the lamotrigine here. And if you can look at this tiripental, it increases several medications because of the enzyme inhibition properties. So the red means, in particular, there is probably enzyme inhibition mechanism going on. Blue means enzyme induction with reduction. There are some of them are a little bit more complex interactions that may be there. So this is very helpful in case if you have not read this article, you looked at this article, I recommend you to take a look at this article. It's pretty useful. Moving on to the next section of other systemic medications, in particular, the use of birth control pills in women in the reproductive age group. So this is a scenario, there is no question here. So just for you to think about it, an 18-year-old young woman with juvenile myoclonic epilepsy on lamotrigine 200 milligram twice daily seeks advice on birth control. What would you recommend? Lamotrigine birth control, that's the issue that we'll talk about here. When you look at drug interactions with the anti-seizure medications or the birth control pills, the most important enzyme system that is involved is the CYP3A4. Because CYP3A4 is the one that increases the clearance of the estrogen component of the, in particular, of the birth control medications. So anything that induces this is going to affect the birth control medication. There is less important mechanism, especially with the older generation medication. By increasing the sex hormone binding globulin by these drugs may reduce free progesterone levels. So if you look at the hepatic enzyme inducing drugs, again, similar, you're probably now familiar with this list of all the medications, and these are the medications that should not be affecting the birth control medication because they are not enzyme inducers. Okay, obviously first generation medication, easy to remember. In the second generation, oxcarbazepine still, eslicarbazepine still, perampanel, topiramate, these are the other medications that we need to be careful about. What are the options? Depot progesterone usually works in majority of situations, almost all the situations. Intrauterine device, either copper containing or hormone-laden IUD, both are equally effective. And of course, there are other methods. Higher dose estrogen is another thing that people recommend. So this is probably a repetition of a previous slide of all the CYP3A4 and medications from the newer medications. All of them could affect the birth control pills. So for the patient on lamotrigine, there is a special situation which everybody is familiar here, I believe, because the estrogen in birth control pills induces UGT1A4, which increases the lamotrigine metabolism, and that's why there is a significant drop in the lamotrigine lamotrigine levels in the system. So the patient is newly exposed to a birth control pill with the estrogen, the lamotrigine levels go down, and patient is at risk for seizures. This is the same thing that happens. That's the same thing that the reason why lamotrigine levels decrease when women are pregnant, because there is an increase in estrogen and the lamotrigine clearance is steadily increased until the delivery. You know, sometimes women may be taking 150 milligram per day of lamotrigine at the beginning of pregnancy, well controlled. What we do here is a monthly check of lamotrigine levels and adjust the dose. And sometimes patients may require as much as 800 milligram of lamotrigine to maintain the same level that is the beginning of the pregnancy. And then the dose need to be suddenly reduced after the delivery, because once the placenta is delivered, I think the enzyme induction due to estrogen plummets. Lamotrigine also can increase the clearance of the steroid metabolism, but it is not sufficient to suppress ovulation, so it should not be affecting the birth control pill as such. So there are studies that shows that there is levels of levonorgestrel reduced with 19%, but this interaction is not clinically significant. This is a nice chart from the Centers for Disease Control. I will walk you through this here. These are the options for the contraception, copper-laden IUD, levonorgestrel-laden IUD implants. I think these subcutaneous implants, and dextroprogesterone depot injection here, progesterone-only pills, and combined hormonal contraceptives. For lamotrigine, you could use all of them except the combined hormonal contraceptives, as theoretically risks outweigh the benefits. Obviously, the birth control measure may not be effective. For patients who are enzyme inducers like the phenytoin, the usual medications, you could use all of these IU devices. Implants also is fairly effective, and depo-progesterone is pretty good, but the progesterone-only pills or even the combined, both of these are not an acceptable birth control measure in the patients on birth control measures, on the anti-seizure medications. Sometimes, at least in our practice here, it's not our gynecologists may require some guidance from us. So we will give them some options. Hey, this is acceptable, this is not acceptable. The patient is at lamotrigine. We do not recommend this. So this is it's a nice cartoon there for quick reference. So the interaction between anti-seizure medications and drugs for other conditions. Okay. So this is another scenario here. There is a multiple choice response. I'm sure everybody will get this one right. A 50-year-old man with focal epilepsy on treatment with carbamazepine for the past year has been seizure-free. He presents to the emergency room with acute onset unsteadiness of gait, slurred speech over the past 24 hours. Examination reveals ataxia and dyssympatria nystagmus. And he was seen by the primary care provider for sore throat 2 days earlier and was prescribed this antibiotic. The antibiotic that likely caused these symptoms are erythromycin, sulfonamide, amoxicillin, cephalexin, Bactrim, and everybody is answering quickly. The answer is erythromycin. Erythromycin is a potent CYP3A4 inhibitor. That's an enzyme that metabolizes carbamazepine, so it can produce significant toxicity. This was a real life scenario once when I was a resident here in neurology. We got what we call a meet me line calls, where patients call from their home with symptoms, and then I'm the on-call person who takes the call. So I could diagnose this on the phone. It's very slurred speech. Obviously, I think I sent him to the emergency room. And sure, he got an MRI scan, making sure that there is no stroke there. But the reason was carbamazepine toxicity due to erythromycin. CYP3A4 is a particular very important enzyme. I don't know whether, I think these days, the medical school, I was asking our medical students here or residents here, and they have special classes on CYP3A4. I think when we were medical students, I don't think anybody talked too much about CYP3A4 during pharmacology. CYP3A4 is involved in metabolism of nearly 50% of marketed drugs. So it's a very important enzyme system. And in epilepsy, the medication that are frequently eliminated by the CYP3A4 are carbamazepine, felbamate, rufinamide, lacosamide, zonisamide, and perampanel. Again, not exclusively by this enzyme, all of them. Carbamazepine is probably predominantly by the CYP3A4. So there are several inhibitors in several different sections. Of course, infectious diseases is probably the most prominent here. Clarithromycin, erythromycin, not azithromycin. Anti-HIV medications, antidepressants, calcium channel blockers, several herbal and dietary components, all those things can produce inhibition of the CYP3A4. And among the inducers, the usual suspects in the anti-seizure medication group, and also the rifampin. So this is a short list of some of the enzyme inducers that can decrease these medications. So this is the effect of anti-seizure medication on these antipsychotic medications, or systemic medications. The most important thing is the anti-neoplastic drugs. And the patients have cancer, they are on multiple medications, and they have a seizure. You need to be careful to avoid any kind of enzyme inducers. It can affect all multiple different systems. Digoxin, for example, warfarin, tacrolimus. We had one patient with the Rasmussen encephalitis. We were treating with the tacrolimus. Patient came to the ICU, was loaded with phenytoin, and then the tacrolimus levels were difficult to maintain. So this can happen in your epilepsy practice as well. As somebody had mentioned in the chat box, the effect of carbapenem antibiotics and valproate. This has been increasingly recognized, especially in the ICU. Obviously, most of the time this happens in the ICU when the patients are having sepsis on valproate for epilepsy, and the valproate levels dramatically fall and patients are at risk for seizures. And this can happen with all the carbapenems that is listed here. The mechanism is poorly understood, and in any case, dose adjustments do not work. So valproate levels, you can keep adjusting, just like my first case and I shared here. We can keep adjusting the dose, but the levels do not pick up. And it's probably a good idea to have an alternate medications, and the levels usually rebound a week after stopping these penems. So this is another antibiotic we need to be aware of. So it is very important when you're starting an enzyme inducer, make sure that what are the other medications patients are on. Especially is important for an adult practice: birth control medications, oral anticoagulants, immunosuppressants, antiviral. So of course you can produce havoc on all these drugs, and avoid an enzyme inducer whenever patients are taking the above medications. And the medication that increases the anti-seizure medication levels. Okay, these are the enzyme inhibiting ones. We talked about the erythromycin, clarithromycin. Again, this is a relatively short list from this publication here. So many of the systemic medications can affect the anti-seizure medication levels. So it's time for some take-home messages here. I hope this was useful. The most important things to remember are the drug interactions are fairly frequent when we are using first generation medications, especially obviously with polytherapy. First generation medication invariably have enzyme induction or inhibition properties. Maybe the only exception may be the ethosuximide there. And the enzyme induction and the de-induction is delayed by 1 to 3 weeks. So anticipate these drug interactions when you're adding an enzyme inducer. What are the medicines levels likely to go down? So keep an eye for it. If needed, do drug levels and monitor. And it's very important when the patients are out of the ICU, anticipate this and proactively check the levels or watch for toxicity effects and then adjust the levels. Of course, in our practice here, we do plenty of levels. I hope nobody asked me questions about anti-epileptic drug monitoring here. So we do probably much more than what is required. Enzyme inhibition interactions, on the contrary, are often acute and dramatic because the enzyme inhibition kicks in quickly, producing toxic levels of the medications. And many of the newer anti-seizure medications have unique drug interactions, especially the most important thing that comes to mind is the cannabidiol and the clobazam interaction. And be aware of the hidden drug interactions, especially the toxic metabolites and epoxide hydrolase inhibitors producing toxic metabolite of carbamazepine. The same thing with clobazam. It's a toxic metabolite of clobazam will be increased. And the other hidden mechanism is the free drugs. So if you don't check the free drug levels, you may not appreciate that the patient is having toxicity due to that drug. And the enzyme inducers affecting the drugs for other indications, particularly important in practice, in adult epilepsy practice, if they are on other medication for other systemic conditions, it's very important to avoid enzyme inducers by all means. And these are some of the key references I have used for this talk. I have particularly liked the first one in terms of the overview of the different mechanisms. In fact, that is the drug. That was the article that excited interest on drug interactions for me. It was in Continuum 2007. And these are the other articles that I found I have heavily leaned on for this presentation. Okay, that's the end of the talk here. I'm going to stop sharing here and happy to take some questions. And
Dr. Musa, it was wonderful, and it was actually amazing talk. You have covered more or less the complete length and breadth of most of the interactions. I'll start with a question from my side. So, because this is a question which we often face while prescribing the anti-seizure medications, that come and ask a blanket question that is it that the newer generation anti-seizure drugs safer and have less interaction than the so-called older generation? And at the same time, are they as effective as the newer generation? So can we make this blanket statement?
Are they safer? I think it's definitely yes. I think we are comparing with the phenytoin, phenobarbital, carbamazepine group compared to whatever is newer generation is after 1995. Felbamate is probably somewhere an exception between. So definitely less drug interactions. If you look at the first 2 or 3 medications we use commonly in practice are levetiracetam, lacosamide, oxcarbazepine, lamotrigine, right? The enzyme induction property is probably the one that produces much more interactions, which is less of an issue with all the medications I listed. Even if they are having some enzyme induction inhibition properties, they are very narrow range and you can obviously manage. So my general impression is newer medications probably give more or less the same kind of seizure control as the older medications, but with less side effects and less need for monitoring, especially less side effects in the long term, phenytoin producing gum hyperplasia, ataxia, cerebellar atrophy, and the effect on the bone density issues with the enzyme induction. So in general, yes. In terms of effectiveness, as you know, it has been shown that the pool of refractory patients have not changed with the use of traditional medications versus newer medications. Is essentially the same. So what is happening with the newer medications is you have safer medications, easy to use, less interactions with the same effect. Of course, there are some special situations where we have newer options like epileptic spasms. We obviously have to go for special medications. Absence seizures, the most effective medicines are all both the older generation. So you can approach this in multiple different ways. I hope that answers your question.
Yeah, more or less. Nayak sir, any comments from your side?
I think first I must compliment Musa for that brilliant talk. I mean, so practical, and he covered the entire topic just by some 6 or 8 examples, and really absolutely practical. And he brought in all the points as to why such a mechanism is operational at what level. And I think that the interaction between the practical aspects as well as the theoretical aspects was so beautifully brought out. So I think that's pretty brilliant. I thought. Now, yeah, I mean, you use a lot of therapeutic drug monitoring in your unit, and you mentioned that you use quite a lot of that. Here, obviously, we don't. I mean, lots of constraints. And also for the newer anti-seizure medications, I don't think it's freely available here. I think now we have for levetiracetam and for lamotrigine, but they're very expensive, and I don't know. I mean, so that's the reason why we generally don't use the. So we go by the rule, thumb rule, like maybe reduction or increase by 30% or 50%. That's the kind of thing that we do. Closely follow up clinically and see, and that's how we have been doing. So that's something that you brought out that very nice chart, where you could monitor the drug levels every week and show us the the levels coming up or going down very illustratively. But such a thing, I don't think we'll be able to do that kind of work out here just because of the constraints that we face. Your comments on that, and how would you?
I agree. I think we do a lot more levels. It's almost like if a patient is on a refractory status in the ICU, most of the times you may be getting daily drug levels in the initial acute phase. Okay. Even if it is not needed, it may be happening like a CBC, CMP kind of thing, maybe drug levels. But if you don't do the drug levels, you are completely oblivious of what's happening. The patient is nicely in coma with midazolam and pentobarb, but the other medicines are not at all in the system and you're weaning off. So sometimes you chase and chase, you don't get to that medicine level. Ultimately, the patient decides no more seizures, and then you wean off, no matter what is there in the system, patient not having seizures. That's probably the truth, you know. It is an explosion that happens, and then you tide over that and then come back. Of course, you feel better when you have good levels when you're taking down the weaning medications. So I think a good clinical sense is it's a sufficient replacement for lack of resources there. And anticipating that a patient is going to have toxicity 2 weeks from now is something that we need to be cognizant about and actively monitoring for. Obviously, the patient's having toxicity, as you said, drop the dose by 30% and see what happens. So that's reasonable.
Yeah, I think the takeaway message that you showed us was those two charts, the nice ones which you walked through. I think that's quite nice to have it in everybody's clinics, so that you could have a ready reckoner. And though the Peruka's the chart, and that's nice, and the CTC chart on the oral contraceptive pills. I think they are very useful, very practical, and it kind of encompasses or sums up all what you have spoken about. And
that's correct. Yeah,
that's very nice. Yeah.
I think we have time for a couple of questions. I'll just club some of them which address a common thing. So one of the questions is by Dr. Meena, that in pregnancy, I think progesterone is the prominent hormone. Still, lamotrigine has to be changed, like lamotrigine has to change like OC pills containing estrogen. So I think what she's trying to ask is that why does lamotrigine have to be changed during?
I mean, the levels.
The levels.
I don't know about how much about the endocrinology of pregnancy, but I thought the estrogen significantly increases, right? Estrogen significantly increases.
An interplay of both the things, yeah.
Yeah, maybe both of them, but I don't know what is proportion. But if you don't make any changes, the levels, again, it is not uniformly in all patients. I think there is a recent report that says that a small percentage may not have any effect on the lamotrigine level. Okay. So it doesn't happen in everybody.
Yeah, there's a related question. There's a related question that please comment on the pregnancy dose adjustments. Should it be done in early or mid-trimester? And how do you judge, and how soon after confinement do you drop to pre-pregnancy levels? Is it 6 weeks target or soon? So basically, when do you do the dose adjustments in pregnancy?
Yeah, I think some of you here may be more knowledgeable about this. Whenever patients are pregnant, we just send them to adult practice. That's what we do here. Okay, I think my understanding is they do monthly levels. And of course, they get a baseline level as soon as the pregnancy is diagnosed, and see if they have a previous level that was controlling the seizures, and try to aim for that level. And I think our practice is monthly, and adjust the levels, adjust the doses. I don't know how you practice there.
Yeah, I have quite a bit of, kind of experience on that, because of course, levels are just now available last maybe a year or so, something like that. But even then, that monitoring that itself, it costs something like 3,000 per test. So it's pretty expensive. So you can't use it monthly. It's very difficult in all situations. So my rule of the thumb is, if somebody is on 200 milligram of lamotrigine pre-pregnancy, and then, the first 12 weeks, no problem. I mean, the same dose. Second trimester when they enter, I would, if I have not done the drug levels earlier, then what I would do is I would start hiking up. I would warn the patient earlier, much earlier itself, that the dose may have to be increased by even up to 100% from your baseline, which means that 200 milligram can become 400, sometimes even maybe more than that. And that is to maintain the same drug level in your body. because it gets diluted. That's the kind of, and then, yeah, I mean, so from the 12th week of 14th week, we start increasing by 50 milligram every 2 weeks. And so that they reach about 400. Again, it's arbitrary, I would say, because if you take a cohort, usually the drop is about 50 to 70%. So use that as a kind of a baseline and then increase the drug proactively to something like something like 350 or 400 and keep it. So this I found to be pretty, it's very practical from our point of view. And I think it has worked pretty well. I mean, so that's how we use our strategy here. That's my simple experience here.
Yeah, so just looking at the estrogen levels during pregnancy, it looks like both of them kind of climb up. As one of the comments, progesterone is definitely more than the estrogen, but the estrogen is not sitting quite there. Definitely
Equally.
increases much more in the third trimester. That's what happens here.
Yeah.
Okay.
Okay. Another question. This is that measurements of blood levels do not usually correlate well enough with the actual brain levels of the drugs. And pharmacogenetic considerations also have to be taken into account along with the pharmacokinetics and dynamics. So your comments on that?
So we always interpret drug levels in the context of the patient's clinical status, right? If the patient is having more seizures, if you have low levels, that's the only thing we have to go by. The tissue levels are not something we are going by. And the same thing if the patient is having, having high levels, not having any toxicity, we do not worry about it also. Okay, as long as it's in the reference range for most of the medications, we do not worry much about it. So everything has to be taken in the clinical context. Pharmacogenetic considerations. In terms of drug interactions, I told you that there are several medications that may be metabolized with the same substrate, but they may not be affected by the same extent by medications. For example, the cannabidiol I was talking about, CYP2C19, the biggest impact is clobazam. It does not have any impact on phenytoin. I don't think we understand those things very well. So there is probably a genetic factor there in a drug and the metabolizing enzyme itself, not necessarily a person-to-person variation. So the only level that is available is your blood level. Okay, you have to use it judiciously.
Mike, any comments on this?
Yeah, I think it's nicely answered by Musa. Yeah, that's true.
Okay, last one for the evening. Why is inhibition pretty soon while the induction is slower in terms of enzyme kinetics?
I do not know that. No idea. That's a good question. Why it happens slowly? No, I suspect it may be related to the half-life of certain enzymes. They're already kicking in. It'll take the time to slowly go up. I have no idea. I've not thought about it. It's a good question.
That's a very good question. Yeah, that's good. I mean, this fact itself is very nice. And then the question that has followed is also very thought-provoking.
So if there are no more questions, we'll end for the day. And thank you so much, both Dr. Naik and Dr. Musa. It was a wonderful evening, and I'm sure each one of our audience enjoyed it as much. Next week, can we have the slide for the next week's talk, please?
Yes, sir.
So next week, we have an equally exciting evening. And the talk is, again, we will have to travel all the way to Cleveland, again, next Wednesday, for this talk on cerebral cortex lobar anatomy and applied aspects, and it is by Dr. Najam. And thank you very much once again to everyone for joining in this evening, and hope to see you next Wednesday as well.
Thank you.
Once again, Dr. Naik, Dr. Musa. Thank you.
Thank you so much,
Thank you.
Vishal, Musa. Naveen, Mini, all of you. Thank you so much. It was a privilege
Thank
and a
you.
pleasure.
Yep. Thank you. Thank you from here as well.
Thank you, sir. Thank you, Dr. Hassan. Thank you.
Bye.
Thank you, sir.
Bye-bye.
Bye-bye.